Hi everyone, this is Aurelie Najm from Glasgow, reporting live from Fukuoka, Japan for Rum Now. I'm in APLAR, and it's actually my second APLAR, and it's just been fantastic so far. A lot of good science, and also a great opportunity to network with colleagues that we don't get to see too often at other conferences sometimes. So it's just been really fantastic. And one of the presentations that really caught my attention was on the first day, the plenary session, and it was about regional disparities and how we treat patients with rheumatoid arthritis across regions of the world, and in APLA countries as well. And it was really interesting to see, first of all, that there were regional disparities in achieving remissions across APLA countries, and there were multiple factors that were um, described for that. One of them was a notable heterogeneity in the workforce repetition for rheumatologists, with countries that had less than 0.3 rheumatologists per 100,000 inhabitants, while some had almost 3, like Japan, for example. So there's like big differences there. But also something that I found really interesting, the medications that are used to treat rheumatoid arthritis were slightly different. And in particular, there was this presentation by this by Professor Takashi, who's a Japanese professor of rheumatology, who was talking about some of the drugs that were not licensed for the treatment of rheumatoid arthritis in Japan, such as hydroxychloroquine. It is licensed for lupus, however, but and so how often they use tacrolimus, for example, while we don't really use it in the UK, and so that was really interesting. But also there was a highlight on tolerance and safety, in particular when it comes to methotrexate, and how it's been known that Japanese population have more side effects for similar doses, and what were the reasons for that. And so there were a few studies presented in that respect. One in particular looking at the polyglutamated form of methotrexate, which is considered as being the active form and can be dosed in the serum. And so the Albany study from the US was taken as a reference for serum concentration increase over time when starting the drug. And that was compared with the MAGIC study, which was a similar study done in Japan. And it was so interesting to see that actually, while the Albany study showed a really nice increase over time of the serum concentration, and so there was a dose and time dependent increase to reach a peak around 20 weeks. In Japanese population for similar doses, it was completely different, with a very, very quick increase in the serum concentration, and so for much lower dose. And at 24 weeks, so after the follow-up, the concentration in the serum of Japanese patient was up to 60% higher, which understandably can lead to more side effects. And so there was then discussions around the rationale of using the 0.3 milligram per kilogram dose, which is something that is not necessarily done, at least in the UK, where a lot of people get 25 milligrams. So a lot of reflection around that, and how maybe for specific populations of patients, we need to go back to this approach to avoid toxicity, but how also increasing the dose of acid folic acid was actually helping to alleviate some of these symptoms. So I found that really interesting, and that's something I'm definitely going to bring back and use in my practice. I will be doing more reporting, and if you are interested in more highlights, follow me on Twitter at Aurelie Roimo, and follow Rum Now for more content. Bye.